Next speaker is Dr. ARUL SELVAN, who is a consultant neurologist at the Department of Neurology at KMCH. And he is going to be talking to us on intelligent interpretation of visual evoked potential. On to you. Is he there with us? Yes. Thank you. Could you unmute yourself?
Yes, I did.
Yeah.
Thank you very much, ma'am, for an invitation. I thank the organizing team for giving me the opportunities. So what is an evoked potential? An evoked potential is the volley of impulses are generated. It's not moving.
Could you move on the slide? Yes.
So evoked potentials is generated from the volley of the impulses, which is produced at the retina when someone is focusing at the retinal nerve fiber layer, and then it is recorded at the occipital cortex. There are a variety of evoked potentials like somatosensory evoked potential, brainstem auditory evoked potential, visual evoked potentials. The basic principle is the same. Generate the evoked potentials, generate the volley of the electrical impulses, and record at the occipital cortex. The visual evoked potential tests a function of the visual pathway from the retina to the occipital cortex. It assesses the integrity of the visual pathways from the optic nerve, optic tract, chiasm, and the radiation up to the occipital cortex. VEPs are the most common diagnostic test. It's very simple. It's been used in the anterior visual pathway. There is another electroretinogram which is useful in retinal disorders. We all know that how the projection happens. The left hemifield represented at the right side, and the right hemifield represented the left occipital cortex. And the P100 is produced at the occipital striate cortex and the peristriate cortex. We know that, well, there are two types of visual evoked potentials are there. One is the pattern reversal visual evoked potentials. Another one is the flash evoked visual responses. We'll go each one in a few minutes. The visual evoked potentials, the pattern is alternate. The patient will be asked to look at the television screen like this, and then the alternate checkerboard pattern with the contrast luminance uses a visual stimulus. This is the most consistent and reproducible and reliable all over the world. And it stimulates a central part of the vision. This is a macula, which represents a central vision. This is a simple diagram which shows the patient looking at the television screen with alternate checkerboard patterns, 3 electrodes, OZ, CZ, and FZ. And this is the recording electrode at the occipital cortex, and this is the reference electrodes and the ground electrodes. This is the International Federation of Clinical Neurophysiology, how we record this, and it's been standardized all over the world. The flash evoked responses, as the contrary, is a single visual flash is given to the periphery of the retina, usually in the peripheral field. Unfortunately, it is inconsistent and not reproducible. So the flash evoked response only indicate the persistence of the functional visual pathway. When someone has got a very poor visual acuity, someone could not cooperate, the comatose patients could not cooperate, the cortical blindness, and the young children who could not clearly focus the television screen. So the limitations of the flash evoked responses is wide variability. It ranges from 100 to 150 milliseconds. You can understand that. And the P100 latencies are unfortunately less reliable. So the general rule when you do the flash evoked response is to indicate some anatomical integrity is intact or not, the absence indicating complete interruption of the visual pathways. The full field pattern reversal visual evoked potential, the abnormalities can be given as a latency criteria when there is a prolongation of the P100 latency, when there is a more than 3 standard deviation, or if there is an intraocular latency between the one eye to the other eye is more than 8 milliseconds, even when the P100 is in the normal range. Another criteria of the abnormality is the amplitude criteria. You look for the amplitude. When there is a drop in amplitude, then you call it as a axonal form of optic neuropathy. The visual evoked potentials are generally generated in the occipital cortex, in the pre-striate and the striate of the occipital cortex. It has got 3 components. One is a negative, positive, and the negative. N75, P100, and N145. But we are most rely on the P100 latency, whether it's delayed or abnormal. This is a normal visual evoked potentials. 100 runs has been done. Over a second run has been produced, and the P100 latency is roughly in these patients 102 milliseconds. The normal values, we do have a 3 standard deviation variation. We collected the normative data, those who do not have any visual symptoms. So each lab has got a own set of range of values, but generally this is the international criteria we form it. 100 milliseconds, 115 to 120 milliseconds are in the borderline range. More than 120 milliseconds are definitely abnormal. The inter-eye latency, as I told you earlier, if the more than 8 milliseconds between the right and left is considered to be also be abnormal. Amplitude is generally if there is a more than 5 microvolt, and then it's considered to be normal. If it is less than 4.5 microvolt, then it has to be abnormal. So monoocular field stimulation, if the abnormality is seen on one eye, the lesion should be anterior to the optic chiasma. We know that the optic chiasm where the fibers cross. The visual evoked potential is normal in unilateral lesions of the optic chiasm and the monocular stimulation because each eye projects into the another occipital lobes. Oh, what happens? Not moving.
Can you?
Yes. The P100 abnormalities delay in latency. I mean, you know that demyelinating optic neuropathy, as in multiple sclerosis, the myelin is very important. When the myelin has been lost, the conduction velocity is not happening because of the nerve impulses has to come the saltatory conduction, and so it's abnormal in demyelinating optic neuropathies. The P100 latencies will be grossly delayed. Not all P100 latencies are demyelinating optic neuropathy. Some of them could be very subtle. A toxic amblyopia like alcohol, tobacco, and vitamin B12 deficiency can also have a drop in amplitude and slight delay in the P100 latencies. So we're not considering as demyelinating optic neuropathies. AION, anterior ischemic optic neuropathy, sarcoidosis, Leber's optic atrophy, leukodystrophy, some of the neurodegenerative disorders, and then Friedreich's ataxia, hereditary spastic paraplegia, and Charcot-Marie tooth disease. They can also have a optic nerve involvement, but it will be very mild and subtle, unlike in multiple sclerosis where the demyelination will be gross and the P100 latencies will be grossly delayed. Another form of optic neuropathy is axonal optic neuropathy, especially seen in the post-traumatic optic neuropathy and the anti-MOG antibody syndromes, and poor visual acuity. Cataract can also cause reduction in the amplitude of the visual evoked potentials, retinal degeneration, severe refractive errors, and maculopathies. In hysteria and malingering, pattern reversal visual evoked potentials can be useful if it is normal. The normal PVPs can also be occasionally reported. I'll just show you some examples. This is the mid-occipital region. The P100 latency is 103 and the amplitude is about 6.3. So this is a normal optic neuropathy, the normal visual evoked potentials on the left. On the right side is also again the P100 latency is 104 milliseconds, amplitude is 9.7. This is a normal one. So VEP is normal, the clinical opinion is normal anterior visual pathways of the function, and there is no evidence of optic neuropathy. So this is the second VEP I'm showing you. This is a mid-occipital region and showing the occipital area, and then P100 latency is 112, and the amplitude is about 4.2, so roughly in the normal range or slightly lower, and the P100 latency is in the borderline. This is the left eye, again P100 latency is 117, amplitude is normal. So upper limit of normal range, mild borderline delay, so might indicate an optic neuropathy, so we should interpret cautiously in the clinical context along with the MRI findings. So this is the third visual evoked potentials example, and then clearly delayed. P100 values is 133 milliseconds and the amplitude is normal. And then left eye 135 milliseconds and the amplitude is again normal, indicating a bilateral optic neuropathy.
1 minute remaining, sir.
Probably due to the demyelination. So to conclude, the pattern reversal evoked potentials are the most sensitive diagnostic tool in finding up the optic neuropathies, especially the demyelinating optic neuropathies. The flash evoked responses are generally of limited use. It does useful when there is uncooperative patients, comatose patients, to find out the anatomical visual pathways integrity. A good laboratory with a trained technician and experienced neurology is an utmost important to produce a good visual evoked potentials pattern. Thank you very much.
Thank you very much, Dr. Selvan. That was a wonderful talk. Just one offbeat question. Is it possible for a malingering patient to cheat a pattern visual evoked potential?
It's perfectly possible because we need to focus. Then only the P100 the volley of the impulses will be generated from the macula, and then it goes into the occipital cortex. So if the patient is not cooperating, they're not focusing on the little mouse on the television screening, then we cannot have a good recording pattern. So they can do that malingering patients. That's why we do the flash evoked responses also. The flash evoked responses is a larger response, is stimulating at the periphery of the retina, not the central vision, and then it gives a response. So malingering patient can do that abnormal VEPs. It's not surprising.
Murli, any questions? Dr. Rohit, any question?
Dr. Arul, Selvan, you had three latencies, one from the mid-occipit, one from the right, and one from the left. So which latency should we be taking? I mean, if you stimulate one eye, you have these three latencies. So
Yeah.
would they be different, and which one should
The Western standard where I was trained in Oxford, in the UK and also in US, we do have a three standard because we do not have a uniform occipital protuberance where we place the OZ 2 centimeter again that. So that's why they all uses the mid occipit 1 or 2 centimeter either left or right to see that the VEPs are reproducible and consistent. But unfortunately, in Indian laboratories, we do use only one channel. So that's acceptable, I think so.
in comatose patient, is there any role for this VEP? I mean, there were some studies on traumatic optic neuropathy which used VEPs to diagnose. Do you do that, sir, in your practice?
No, we do the brain death can be confirmed with the most one of the sensitive tests is the somatosensory work potentials from the median and tibial nerves. But we don't use the optic nerve to confirm the brain death or the activities. But certainly the somatosensory work potentials do have a higher values in diagnosing the brain death patients.
Okay. Thank you very much, Dr.